Good morning and welcome to our Asthma Allergy Education Workshop. This is the third session in this series. My name is Megan Ahmad. Thank you for joining us today. I would like to thank our sponsors for making this event possible. For any queries, please email admin@allergyfoundation.co.za. The recording of today's webinar will be available to anyone who's registered. Please keep an eye on your inbox. Our program today will be led by an awesome panel of experts, including Prof. Mike Levine, Prof. Charles Verwey, and Dr. Pieter de Waal. For any medical professionals in the audience, please note that this is not a CPD activity. Before we get started, I'd like to go over some basic housekeeping. This is quite important, especially for those joining us for the first time. This is to ensure that you understand the icons displayed on your screen. You will notice a taskbar in the top right-hand corner of your screen. Our audience is muted and will remain muted for the full duration of the session today, and we will not use the hand up function. Instead, we encourage you to post your questions in the Questions tab. Our panel of experts will answer these questions during the talks and in the Q&A session just before the end of the webinar today. You may use the React button to interact with the panel by sending your reactions. Today's program and other downloadable content may be found in the Materials tab. This information is also available on the AFSA website. We are excited about this Allergy Education Workshop series, which is specifically aimed at patients, parents, caregivers, educators, and those wanting to learn more about allergy management. Our final session for this year will take place on the 27th of September with a focus on eczema. These sessions are free to attend. I've included this slide in the Materials tab, so please feel free to download and share. Also, email admin@allergyfoundation.co.za for more information. Follow us on social media and sign up for our free newsletter to receive updates. I've included the registration link and link to the free MP4 on eczema on the slide. So remember, you are able to download this from the Materials tab. Please visit our website, that's www.allergyfoundation.co.za, to learn more about what we do and what we offer. Sign up for our newsletter, browse our articles and free downloadable content, and explore the products under the AFSA seal of approval. Visit the AFSA shop to purchase our in-house products, such as the AfriSpacer device to use with an inhaler, and the Kitty Calmware range of eczema clothing for kids. And lastly, before we continue with the program, I'd like to mention that we have some prizes up for grabs today. We have an air purifier unit sponsored by Salenco worth 3,000 Rand, a Beat Allergy pack from Mrs. Martins valued at 500 Rand, and 3 AfriSpacer packs valued at 200 Rand each. Winners will be randomly selected and announced live at the end of the session today. Thank you so much. I just ask you for your attention before we start the program as I play 2 in-house videos.
Looking for products that are safe for allergy sufferers? The AFSA seal of approval is here to help. This trusted seal is awarded to products that comply with our strict quality criteria. Look for it on body care products, air conditioners and purifiers, medical bracelets, nasal sprays and washouts, eczema clothing, cleaning products, and many more. Choose your products with confidence. Look for the AFSA seal of approval or visit allergyfoundation.co.za to view the available products.
Welcome everybody, and if you're up in Joburg, I hope you're keeping warm. It's quite a cold day this morning, so thank you all for joining us. I see there's almost 100 people on the call now, and hopefully that'll increase with as the day goes on. So I've been tasked to talk about what is asthma and to try to explain, and I hope I'm going to be able to do that, because I think there's a lot of misconceptions about what asthma is. People often define asthma as a patient has trouble breathing, they have a tight chest, there's swelling of the airways, there's coughing fits, wheezing, breathlessness. People often think, I know my mother did, that it's a lifelong sentence. And then also that it's caused by allergies and can be caused by exercise. People also mistakenly think that it's just a childhood illness and it only happens when you're sick. And there's even a decent amount of people that thinks it's just a psychological disease. And even though it has a psychological element, it definitely isn't just a psychological disease. People also think that asthma is a disease that you need inhalers when you have an attack and that it's contagious. But we know that it's not contagious. So that's wrong as well. And it's only a serious disease and one we need to think about really if you have to go to hospital with it. And I really hope that's something I can convince you guys that that's not the case. And unfortunately, many people think that when you do have asthma, then you can't do sports or participate in sports, or you can't even try to participate in sports. And I'd love to break that myth completely, because, and I'll get into more details about why I don't believe that at all. So what exactly is asthma? And I hope that I can cause, uncomplicate things and cause a bit of a light bulb moment. But I'll start with the complicated things. And the complicated things is just that asthma is a disease of chronic airway inflammation. There's inflammation or irritation of the airway, and the airway is the pipes that lead the air to the lungs themselves, and it's chronic. In other words, it's not a once-off thing. It's chronic. It's going to stay for a long time, and it won't just go away. So it's a chronic disease. And the inflammation that we have in those airways, in the pipes that we call the bronchioles and the bronchi, cause airway obstruction. In other words, there's narrowing of the airways. And that this causes your clinical symptoms. Because when we have a tight pipe or a narrow pipe, we'll have the symptoms of wheezing. There'll be shortness of breath. The chest will feel tight, and you can have a cough. And it's usually a non-productive cough, a dry cough that the children get. And this is all due to the inflammation that causes the airway obstruction. So I'm going to play this video, and I'm going to hope there's sound to it now. So let's just see if I can do that. It might be that I won't have the necessary IT skills. Oops, sorry, my bad. Okay, now I'm lost completely. Oh, there we go. I've found it there. Okay. And I hope you all heard that. I'll play it again. I know it's quite soft, but that's probably realistic because wheezing isn't that loud often. And it can be just a subtle noise, as we've heard. There's a it's almost as if the children are battling to exhale the air, and that's exactly what's happening. In asthma, there's a problem with exhaling the air because of the tightness of the pipes in the chest, and because of that, you get that sound that we call a wheeze. And it's usually a musical, depends on what music you like, obviously. Quite a high-pitched sound, and we hear it often first on expiration. But later on we can hear it on expiration and inspiration as it gets worse, or we can hear it in both as well. So it can be through any part of the breathing cycle. But I think it's very important to know as well that not all noisy breathing that we have in children is actually due to asthma. There are so many things, and I think that's one of the important things, especially in your younger children, your children under 5, is that when we make a diagnosis of asthma, we need to be very careful that we've excluded many other causes of wheezing or noisy breathing in children. There's many serious and very correctable diseases that can cause wheezing or noisy breathing. So not all wheezing is asthma, but we know that wheezing suggests there's blockage or narrowing of the airway, and anything that causes blockage or narrowing of the airway can cause wheezing. And it can be widespread, and this is more for the doctors in the audience, if you have a wheezing throughout the chest, different sounds of wheezing throughout the chest on both sides, it's usually due to something that's widespread, a widespread process like asthma. But if we have it just on one side, such in one segment of the lungs or in one lung itself, then we need to worry about something very local causing blockage of the airways. And the things that come to mind there in South Africa is like tuberculosis that can cause that, but also a child that has ingested a foreign body and is choked and now has a foreign body stuck in the airways. I'm not going to go through all that list there because it's not, the list itself isn't that important. I think the importance of this slide is to know that there are many different causes of wheezing, especially in the younger children, and that before we can make a definitive diagnosis of asthma in the young child, especially, we need to rule out many of those causes. So once again, asthma can present with symptoms of wheezing, shortness of breath, chest tightness and cough, but many diseases can look like this as well, and we need to exclude those diseases. We have inflammation in the airways, and asthma is a disease of inflammation, very important because of the management that we give for asthma. The main management, the core of the management against asthma is the medications that is actually targeted towards the inflammation of the airways. And if we can get rid of the inflammation or control the inflammation, then we should be able to control the airway hyperresponsiveness or irritability of the airways and the clinical symptoms. So we brought a new concept in there. It's airway hyperresponsiveness. In the previous one, it was airway obstruction. And both of these are important. You have lungs, or you have airways in the lungs that are narrow, obstructed, but you also have irritable airways that are more reactive to outside stimuli, such as allergies or cold air. I went for a cycle this morning, and I must say, in this 3-4 degree weather, dry, cold weather, I feel like I have the symptoms of chest tightness this morning, and that's because of irritation of my airways because of the cold air. And in patients with asthma, the irritation is often heightened, or they have hyper irritable airways in a way. So many things can cause that to become worse. We often call it twitchy airways. And all of these, the airway hyperresponsiveness basically means that the muscles in the airways pull tight and contract. And this can, as I've mentioned, be due to allergic triggers or non-allergic triggers, which we call irritants, such as cold air. And this is where the emotional stress even comes in. Emotional stress can be a non-allergic trigger as well. Okay, so moving on with the diagnosis, we've mentioned a few things now. We've said that asthma is a disease of chronic airway inflammation, and it usually manifests through the symptoms of wheezing, shortness of breath, chest tightness, or coughing. But also important note with asthmatics or with asthma is that the symptoms vary over time. And often you'll find that when a child has asthma, as soon as you take him to the doctor, all the symptoms are gone. And the doctor sits and goes, really? But that is the hallmark of asthma. The symptoms vary over time, and the symptoms vary in intensity. You can have a long stretch where you don't have any symptoms, and all of a sudden, because of heightened inflammation, your airways can become very twitchy and irritable, and then respond very severely to a specific stimulus. So the symptoms that you get can be gone for a long time and then come back and vary in time and intensity. Important thing to notice, as we've mentioned already, the airway muscle spasm is that's caused by the airway hyperresponsiveness. That's the symptom that causes the clinical symptoms, and these can be reversed with asthma pumps or nebulizers. That's important, that the spasm gets reversed by asthma pumps or nebulizers, especially your beta agonists. But the inflammation, we treat the inflammation also with pumps, but those are the steroids, and that's why we have different medications that we use in asthma management. Okay, so last part of the definition, we've got chronic airway inflammation, we've got wheeze, shortness of breath, chest tightness, and cough due to this airway inflammation, and the symptoms we now know vary over time and vary in intensity. We can also reverse the airway obstruction in the majority, 99% of the cases. And that's important in asthma. In the same way that there's spasm of the airways and the airways are twitchy and they close up because of the muscle spasm, in the same way we can reverse this airway obstruction. I'm going to show a video here quickly of just what I'm talking about. So you can have a look for a second. You can see in this child in this video that we're showing now how this child is struggling to breathe. There's shortness of breath, there's a tight chest, and now we give the the MDI, the short-acting beta agonist, through the spacer, obviously, because that's the most effective way and efficient way of presenting the medication to the child. And you can see a few minutes later, 10, 15 minutes later, the shortness of breath and that difficulty of breathing that the child displayed initially has basically gone, or at least improved quite dramatically. And that is what we call bronchodilator reversibility, or the fact that we can reverse the symptoms of asthma. We give the medication, and the symptoms of asthma should respond to the medication, and the child should improve quite drastically. And that's also one of the things we use to diagnose asthma, is that we can show that there's reversibility of the symptoms to the medication that we give. And this is the difference between asthma and a lot of viral infections that young children get. Generally, in children with viral infections, there's not much of a response to a bronchodilator. And the bronchodilator test that we call the bronchodilator test is not positive. So there's no response and no improvement in the symptoms. Okay, so the easy definition then, all in a nutshell, is that asthma is recurrent episodes of reversible airway obstruction. So we notice recurrent, it's usually not just one, it's a chronic disease, so it comes and goes, but it's always there and it's recurrent. There's reversible, we can reverse the symptoms, and there's airway obstruction. And the airway obstruction is caused by the airway spasm, the inflammation, and the mucus production. So you can see in that picture there, the normal bronchiole is nice and patent or nice and open. And on the picture on the right, you can see there the mucus inside, the spasming of the muscles and the inflammation causing the redness of the airways. And because of that, we have the symptoms of asthma. So we mentioned earlier that asthma has the symptoms of shortness of breath, wheezing, chest tightness, and cough, but there are more clues. It's usually a non-productive cough. So a dry cough, as we also say. So if you have a productive or a nice, juicy, fruity cough, it's generally not seen to be typical of asthma. The other things is, it's, as I've mentioned before, it's often triggered by irritants or allergens, irritants being many things like cold air, the smoke inhalation from environmental tobacco smoke exposure, and emotional stress as well. And it varies over hours, days, or months. So as we said, it's recurrent, but it also varies in intensity. Of the symptoms vary in intensity. We can reverse it with asthma pumps, and often there's a family history or of allergies or asthma, or a personal history of allergies themselves, and other features of allergies such as eczema, allergic rhinitis, and those things, because they all form a bigger picture of allergies in the patient. You saw the video there that I showed of the little young lady that was very tight chested, and then we did give her the bronchodilator through a spacer, and that's one of the hallmarks of asthma, is that it's reversible. And we'd like to prove that when we want to diagnose asthma, so we want to prove that there is reversibility. So there's a few obvious ways to do it, and one is if you have a child who's allergic to cats and who knows that every time they come around to a place with cats, their chest is going to pull tight. That is quite obvious. So the triggers can be obvious and easy to elicit, but it's not always that simple. We don't always find triggers that easily. We saw in that video that little lady had a response to a bronchodilator, so that's almost diagnostic of bronchodilator reversibility. But we can look for other ways or other evidence to show reversibility as well. We can witness it, as we've said. We can do the peak flow test, and there's the peak flow meter right there in front of us. Nice, cheap, and easy to use piece of equipment that's very helpful in patients with asthma. We can do lung function tests, a bit more complicated, and they require a bit more cooperation from the child. Or we can do exercise challenge tests. If you have a child that always gets tight chested or says they're short of breath when they run around and they start wheezing, we can do an exercise challenge test. So we do a lung function or peak flow, and we tell them, please go run around for a few minutes, preferably in the cold air as well. That would help as well. And then 15 minutes later, then we can do another lung function or peak flow, and there should be quite a decrease in the flows of the child, which shows us that there is almost the opposite of reversibility, that we can actually cause them to become tight-chested, which is a hallmark of asthma as well. And then they respond to treatment. Sometimes you'll see that a child won't have obvious triggers, or we won't have obvious bronchodilatory reversibility, anything like that. But if we put them on asthma treatment and we reassess them monthly for a few months, we can actually see, by virtue of asthma diary, where they write down their symptoms every day, we can see how the symptoms improve. And that's also an indirect way of proving that there is asthma on board. So I've given the very long definition now of asthma, but I want to. People often ask, "But why? Who cares?" But who cares? It's not a very. Who cares if children have asthma? Not many children have it, but that's not true. I mean, asthma is the most common chronic disease in South African children, and in children globally for that matter, and it affects up to 20% of the population. I think South Africa's latest figures were 10 to 12%, if I remember correctly. But also more importantly is that even though our asthma prevalence is sitting at about 10% for all ages in South Africa, our mortality rate from asthma is extremely high. And that's one record we wouldn't like. I see that red bar has fallen down a bit. It's highlighting Fiji, the red circle, but it should be South Africa. And you can see that even though we've improved over the last 10 or so years with our asthma management and decrease in mortality, we're still third in the world when it comes to mortality or children dying from asthma. And that is the big problem. And one of the biggest reasons for this is because there's no education around asthma, and people in the communities don't seem to take asthma seriously. They don't see it as a serious disease. They just see it as something that children get, and it's not that severe. It can be just managed, and that is not true, as you can see by the mortality rate that we do have. There's also a tendency in South Africa and many African and global countries that we rely overly on our reliever pumps, on the short-acting beta agonists, salbutamol pumps. And as we've seen on many of the slides before this, that asthma's main problem is actually inflammation of the airways, for which you need inhaled corticosteroids to manage that. And that's a very important part of the management, is not the over-reliance on the relievers, but actually having proper controllers. And with those, we should be able to manage and get rid of all the symptoms as they come. So how do we manage asthma? It's just not just medication. It's much bigger than that. And I know some of the panel will be talking about that as we carry on. Patient education is, and that's hopefully what we're doing here today, is one of the most important aspects of management of asthma. There's no point in having great medications available and great spaces available, but the medicine doesn't actually get given. So we need to educate regarding the giving of the medication and how we give the medication. The inhaler technique needs to be solid and checked, and every time that the child comes to a healthcare practitioner, they need to go over the technique of how it's given to make sure that it gets given properly. Else there's no point in giving it. We need to look at this, educate the families and the children themselves about the symptoms that we get from asthma, and when to know that it's the start of an asthma attack or that their asthma isn't under control. And we can give things like asthma plans, which guides the family of the asthmatic patient on how to look out for danger signs, and then what to do when these arise, so that we can get the treatment for asthma in quite early. We also need to educate on allergen and trigger avoidance. If you are allergic to pets, unfortunately, we're not going to be able to manage your asthma brilliantly if your house is full of pets. Pollen is difficult. Mold we can work on. Cigarette smoke, it's always so depressing when a child with poorly controlled asthma comes to the hospital and is very sick. And then when we start talking, we find out that both parents are smoking at home. So we need to educate about triggers, about trigger avoidance. Some things are more easier than others, but a lot of things that we can do. When we go into details about the family situation, there are a lot of things we can actually manage. Then you can see the third block there is pharmacotherapy, and that's the controllers and the relievers. We need to control the disease themselves, and that's usually the inhaled corticosteroids. And then we can relieve the symptoms with a lot of the other medications as well. And one thing we often forget is that we need to treat the comorbidities. There's no point in just treating the asthma, but then the allergic rhinitis that the child has is out of control, or there's other things that we can actually control as well, such as obesity and gastroesophageal reflux disease and food allergy that might be making the asthma worse. So I mentioned earlier on the goals of asthma treatment, and for those who are looking forward today to probably one of the most exciting stages of the Tour de France, that's an old picture of the Tour de France there. And I'm not saying we want to develop two of the most phenomenal cyclists ever, because that's just hopeful and dreams. But asthmatics should be able to lead a completely normal and physically active life, and that's very important. We want asthma control, we want control of the symptoms, and we need everybody to be able to lead a normal and physically active life. They need to basically be completely free from any symptoms, attend school regularly, and participate fully in all school activities, including sport. They need to be able to sleep free from nighttime cough or wheeze, grow and develop normally. We need to minimize attacks of acute asthma and avoid hospitalization and, heaven forbid, morbidity or patients passing away from asthma as well. And we need to also avoid and minimize the medication side effects. So that's important. That's one of the pillars of the asthma management, is to lead. We need to aim for a goal that's much higher than we often aim for, and that's to lead a normal and physically active life. And the principles of management are simple. We need to control the inflammation that is the hallmark of asthma. So we need to control the airway inflammation, and for that we use the inhaled corticosteroids initially. And then we need to know our medication, so we need to know what's going on and what we're giving. So we need to know what controllers we're on, what relievers we're on. We need to know all the different kinds of medication. That will be discussed a bit later as well. We need to use the medication as prescribed. We need to use the best technique available to make sure that we're actually getting the medication into the children's lungs or where they need it. And we need to aim for symptom prevention as well. So I'm just going to go through this last one or two slides and saying we often follow a stepwise approach to asthma treatment itself. And the first, we call the GINA guidelines. That's what they use. And the first step is for patients who have very few symptoms. And then if those symptoms become more, or if the symptoms are uncontrolled, we step up to more regular treatment. And then step 3 is when they have even more symptoms, more uncontrolled, then we'll move up. So up to higher doses or add on more treatment. So it's a very stepwise way of treating asthma, and we need to see how many symptoms they have and what type of symptoms they have, and we need to adapt the medication that we give them all the time. And we generally use this this chart that's showing over here, where we ask if there's daytime symptoms less or more than twice a week, if there's any nighttime symptoms or waking due to asthma, how many times they've used their reliever in the last week or so, or in the past 4 weeks, and if there's any activity limitation due to asthma. And if those answers are yes, if none of those are yes, if they're all no, then we're very happy. Then we can say the asthma is well controlled and we can keep the medication as it is, or even try to decrease the medication. But if those symptoms are there, just some of them are there, like 1 or 2 of those symptoms are there, then we call partially controlled. And then we need to look into many other factors of why the asthma is not completely controlled. We can also increase the medication if we want to, or do lifestyle adjustment. And to be uncontrolled, you need most of those symptoms positive. And that's the dangerous part of the children with asthma. And those ones we definitely need to adapt the management and the treatment of these children. So I'm going to bring your attention to the asthma treatment chart. These are all the medications currently available in South Africa for asthma. You can order these through ALSA and through the South African Thoracic Society and the National Asthma Educational Program. And that just gives people a good idea of what is available for the different types of asthma treatment.
Charles, sorry to
And oh,
interrupt. I just want to
yes,
check, can everybody still see your screen? Can everybody still see Charles' screen or not?
there's
No,
something
I
happened again.
think it's just gone
Oh,
off in
wow.
the last slide, Charles.
Okay, okay. Well, the last slide is going to be a scary one. And for the simple reason
There
that
we go.
that's the scary slide. But I'm just going to go back quickly. So as I was talking about the symptoms monitoring, is we're looking at here, looking for any symptoms over the last 4 weeks. And this is the asthma poster that is available through those different organizations and very helpful, especially for education. I think it's very important that children need to know exactly what they're on. So they need to know the name of it, what it looks like, so they can be in charge or in control of their own asthma management. And then yeah, there's those two guys. I'm not sure what this slide is for. Oh, there's a picture. Okay. So now I'm going to show a video quickly, and that's the talk from me for this morning.
So I'm out of medicine, studied medicine, don't remember anything. I don't know why you're asking me to give advice.
Well, I hope you remember something, Riyad, because I've got some medical questions for you.
Okay.
So why do you think asthma is important in South Africa?
Okay, first of all, in Cape Town, it's pronounced asthma.
Of course.
I'm not sure you're aware of that, Prof. Asthma. Asthma, as far as I know, it's extremely common. It's apparently like 20% of kids and 10% of adults have asthma. And the big thing about asthma, symptomatically, it's preventable. This is the problem, bruh. If people just used the medication properly, it could prevent, I don't know, what percentage of the admissions into a Red Cross hospital and the multiple hospitals across the country, right? But if it's used as in a preventative way, effectively, right, it's much better. People don't understand they must use like the metered dose inhaler and the spacer as a prevention and not a treatment.
Special two people, those actually. So in conclusion, I'd just like to say that asthma, as we've mentioned, is the most common chronic non-communicable disease in children. It's based on airway inflammation, and that's the important part, and that's what we need to treat, and that's why we need to take medication regularly. Anti-inflammatory treatment for this inflammation is always necessary because that's what's going to stop the asthma at the root of its cause, which is inflammation. And for that, inhaled corticosteroids are by far the best treatment. And there are other treatments available, but the first line treatment for asthmatics should be inhaled corticosteroids because that is the best way of stopping the inflammation that causes asthma. We need to aim for control, full control. We don't want to just treat the symptoms. We want healthy, physically active children with asthma running around like everybody else. We need everybody to understand their medications, why they're taking it, what they're taking, how they need to take it, because that'll drastically improve the control that we have over asthma in our population. And we need to use the medications as prescribed and with the best possible technique. Because as I've said, it doesn't matter if we have the best medications available, and we do have them available. If we're not taking them properly, they won't do any good for us. Okay, so on that note, I want to say thank you very much. Thank you to AFSA for giving me this opportunity, and thank you everybody for tuning in on this lovely Saturday morning.
So I'm going to speak to you about asthma treatment approaches, which is basically just a short overview also about, or a short overview on different approaches that we can use when treating asthma. So I think Prof. Shah also highlighted this already. It's a chronic condition. So why is this important? It means that you need to take your medicine basically every day or chronically. It's not a 7-day antibiotic course and then you're cured of your asthma. It's a chronic lung condition and you need to treat it basically every day and on a chronic basis. There is inflammation of the airways of the lungs or the walls of the airways, and that makes it sort of or necessitate the use of inhaled corticosteroids. And it's important to remember that even if you don't have any symptoms, you still have underlying airway inflammation. We've had quite a few questions already this morning that the answer to is increase your preventer or increase your inhaled corticosteroid treatment. That is really the answer of treating asthma. Spasms leads to acute attacks. I think Prof. Verwey also highlighted that. Spasms is reversible, so that's one of the ways that we diagnose asthma. And the underlying cause can be treated and should prevent future attacks. And then don't just treat symptoms. It's not a coughing syrup that we're giving to you to treat symptoms. It's really to address the underlying inflammation and really address the problem or the root of the problem. So when we talk about asthma medication, it's really easy to try and remember controllers versus relievers. So it says, or it does exactly what it says. Controllers means that you are treating the underlying cause of your asthma, and that is inflammation. They're usually used to treat or on a maintenance basis, and they're usually given or prescribed like a once or twice daily treatment frequency, depending on your severity of your asthma. And like we said, it reduces airway inflammation, so they prevent future attacks. Relievers, on the other hand, is really to relieve acute asthma symptoms. So it's a short-term relief of bronchospasm, or when your airways starts getting twitchy or they close up. It's really not meant to be used on a long-term basis, and really not it shouldn't be used to prevent future attacks. It's really a rescue treatment. It's used as required. And like we said, it really addresses airway spasms or airway twitchiness. It doesn't really address your underlying airway inflammation. So I think a big message, or a huge or a loud message of today's talks, of all our talks, is simply treating attacks or asthma attacks when they happen is just not enough. Asthma is not a rescue, or asthma treatment should not be based on a rescue treatment, but it should really be based on preventing future attacks or preventative treatment. There are a few dangers of using your reliever without a controller, or overusing your reliever. And there's been a huge sort of movement the past few years towards SABA overuse or SABA abuse, short-acting beta-2 agonist abuse. That's your reliever abuse. And studies have shown that if you overuse your reliever, your little Astavent or your little blue pump, you can mask or just mask poor asthma control, which is dangerous. There's also danger of future asthma attacks. You do increase your risk of asthma-related deaths. And these reliever medicine do have side effects. So be careful of overusing your reliever medicine. What is the golden rule? It just means that if you need your reliever medicine 3 times a week or more, it means that your asthma is poorly controlled and you need better controller, or you need to step up on your controller medicine, not your reliever medicine. And you can see that little nebulizer there on the slide. It's remember, that's also just a form of rescue medicine. So people often think about rescue treatment as just treatment in a pump or an aerosol or a little spray form. But also, if you need your nebulizer, which is, by the way, a terrible use or a terrible way of giving your asthma treatment, if you overuse that, that's also a sign of reliever overuse or reliever overdependence. So let's look at a few examples. Controllers, like we said, or preventers. Some people call them the preventers because they prevent future attacks, and they are inhaled steroids with or without a combination of either a long or a quick-acting bronchodilator. Remember, there's also Montelukast. Montelukast is just in a tablet or a sprinkle or a chewable form. It's kind of an antihistamine, but it also has anti-inflammatory properties. So that's why it can be used for asthma or anti-inflammatory asthma treatment. Just remember, it doesn't work as well as inhaled corticosteroids. On the other hand, you have your relievers or your bronchodilators. They are usually quick-acting bronchodilators because they're supposed to work quick in an emergency situation. Sometimes we can also rely on anticholinergic medication that blocks certain nerves that causes bronchospasms. They are usually also classified as quick-acting bronchodilators. And then we sometimes use a combination of inhaled corticosteroids with a quick form of a bronchodilator. So remember the golden rule. Controllers must be used every day to address your inflammation, and reliever are really should only be used, should not be abused or overused, and it really should only be used when you have symptoms. So we are moving towards giving controllers and relievers kind of together, because studies have shown that the two is a good marriage with each other. If you give a controller, or if you give your reliever and also at the same time give your controller with it, it means that you actually step up while addressing or during addressing your underlying airway inflammation. So remember that one medication can be both a controller and a reliever, and we can use it basically in two different ways. We talk about the anti-inflammatory reliever strategy or approach, or the AIR approach, and that's usually for patients that need it on demand basis. So basically you give your inhaled corticosteroid with your bronchodilator at the same time when your asthma isn't that bad or fairly infrequent. And whenever you need a reliever, you also give a controller at the same time. On the other hand, you can use smart therapy or single maintenance and reliever therapy. So that means you basically use it on a more chronic basis. You use your controller therapy in the morning and at night as you would use your inhaled corticosteroid. But because it has a quick acting bronchodilator with it, you can also use it on demand. So during the day, you can use it when you feel your symptoms or chest symptoms are not well controlled. You can top yourself up with an extra additional inhaled corticosteroid and bronchodilator doses at the same time. So that's called the SMART therapy. So a few principles of asthma management. Prof. Verwey already mentioned these. Regardless of medication, remember your principles remain the same. There's only a handful of medication that we can use for asthma treatment, and they basically work very well in each and every patient that remembers to take them every day and use it the right way. But you should know what medication is which one, what is your reliever, what is your controller, when you should use it, and then obviously your technique of using it. There's absolutely no use in having a very grand and very expensive medicine, but they do not get into the lungs effectively where they're supposed to work. I think it's also important to remember your triggers, know your triggers. We've answered already a few questions this morning about cold weather, about cats, about environmental pollution. These are very important to identify and get tested for these so that you know what exactly is your triggers. I don't need to talk about cigarette smoking and now the new kid on the block, vaping, which in many aspects are more dangerous to asthmatics or allergic patients compared to cigarette smoking. So vaping and cigarette smoking is a big no-no in patients suffering from asthma. Use your medication as prescribed and use your medication with the best possible technique. Monitor your symptoms and make sure that you identify early if your asthma symptoms are losing or if you are losing asthma control. And it's important that do not rely on treating symptoms, rather focus on preventing future attacks. And there you can see there's many different devices where how we can deliver asthma into the lungs. And it's important that the one device isn't necessarily better than the other one as long as you know how to use these devices, your technique. And if you're unsure, please ask your nurse or your asthma care provider to demonstrate these to you. So what are the aims? We've already highlighted these. Self-awareness. We aim for a self-managing asthmatic that is able to recognize loss of asthma control. Asthmatics should be completely free of symptoms. They should attend school normally. They should do sports and other leisure activities like any other person. They should grow and develop normally. And then obviously future hospitalization and asthma attacks should be minimized. And then we should also at the same time aim for absolutely no side effects. And remember that although we are using inhaled corticosteroid, it is a corticosteroid. It should be prescribed safely, and in most instances do not, if prescribed correctly and used correctly, doesn't have any side effects or systemic side effects compared to things like prednisone or systemic corticosteroid tablets. So we use the zones of asthma control, and this is really so that you can recognize when your asthma is getting out of control. We talk about the green zone, that's your go zone. This is where you want to be most of the time. Your symptoms are well controlled. You can do your games and your sports normally. You sleep well. You do not at all use your reliever or your Astavent medicine, or it's less than thrice a week. And if you have access to a peak flow or you have a home peak flow monitoring, that peak flow is more than 80% of best. But this is your orange zone. Then you get into the cautious zone or the caution zone. Now the light is turning orange. It means, wait a minute, something is getting out of control here. Your asthma symptoms are getting worse. You're starting to either cough, wheeze, or having a tight chest. You have intolerance, or you realize that you cannot do sports and your daily activities as before. Start waking up uh, uh, during the night, and you realize that you are using your reliever medication more often, and your peak flow is getting less or less optimal. And then your red zone, this is where your asthma is starting to get really critical. You have either a silent chest or a loud wheeze. You are short of breath. You have difficulty, or you cannot talk at all, and your reliever pump is not working anymore. And this is where your peak flow is really terrible, and according to definition, less than 50% of your personal or predicted best. So what should you do when you are in the green zone? This is really like the zone where you want to be. As we've said, take your medicine normally. Take your 1 to 2 inhalations of controller every day, even if you don't have any symptoms. But your reliever is really in the green zone, really not needed at all. Your lungs are open, and you are avoiding your triggers or allergens, like we've said. And remember that asthma and allergic rhinitis or hay fever are closely linked. We know that about 80-90% of patients with asthma also have hay fever. And if the one is not controlled, it can sort of cause the other one to also become uncontrolled. So make sure your hay fever symptoms are well controlled. And this is really where you should still continue to see your doctor or healthcare provider, but on a less frequent basis, depending on your asthma severity. In the orange zone, this is where your asthma treatment need to be stepped up, or you use your reliever therapy. So we normally say you continue with your controller therapy as normal or in the green zone, but you are increasing your reliever therapy until you are back in the green zone. So this might take a day or 2 or 3, but it's basically where you increase your reliever therapy or use your reliever in conjunction with controller until you are better controlled, or until 2 or 3 days later you are better. Still avoiding your allergens or triggers, or revisiting what exactly could be your triggers or what could be the cause of your allergy getting out of control. Make sure your hay fever is well controlled, and then you should, when you do not get better, but definitely visit your asthma control or your asthma care provider or your doctor. And then the red zone is really where you don't have any time to waste. You should get help urgently, call an ambulance. And this is where we talk about an acute asthma attack, which can be life-threatening and should be treated as soon as possible. In the meantime, while you are waiting for an ambulance or for someone to take you to the doctor, we treat it with what we call multidosing, and that's really one puff of your reliever that can be given via a spacer every minute. So you literally give one puff every minute for about 10 minutes. And thereafter, if you feel that it's not using or helping, I think often what we do, or what parents often do when it comes to children, they wait until they get to the emergency department to get treatment. Emergency asthma treatment should start already at home with your reliever administration. So don't wait to get to the hospital where you can be nebulized or given medicine. Start already with your short-acting reliever medicine at home, or your quick-acting reliever medicine. Start already at home. Don't wait for you to arrive at the hospital. Obviously, keep calm. You can sit up to assist when you have a difficulty in breathing. And then obviously, please remember to visit your doctor as soon as possible after your acute exacerbation. It means that we have to revisit your whole asthma treatment. We have to look what exactly caused your asthma attack or your asthma exacerbation, and we need to adjust your treatment, either step up your treatment or do something different with your controller treatment. And that is my talk.
Thanks, Peter, for an awesome talk. Thanks, Peter, for an awesome talk. I'm going to go on now to build on what Charles and Peter have covered. Amazing now, I'm hoping that you all clearly understand the background of asthma, about the swelling in the airways that needs the controller therapy and the spasm of the airways that needs the reliever therapy. The question though at this stage is, how do we actually get that stuff into your body in the most effective, efficient way? So let's see if I can get this thing to actually go forward. Ay caramba. Why is it not going forward? Okay, right. So the most important thing is to remember that we're trying to give medications to the chest where the problem actually is. And one of the other big misconceptions that we haven't mentioned yet and dangers that we haven't warned you about yet is using medications like oral steroids that go all the way to the body and cause problems with your, they can cause problems with your heart, with your metabolism, with your skin. Those oral steroids or the injectable steroids that people get, they are very, very necessary if you're having a severe asthma attack. But if you're having lots of those medications, you're going to get lots of side effects. Whereas the medications we're talking about now are delivered directly to the lungs, thereby avoiding most of the side effects that you have of these medications at all. And often we believe as doctors and as patients that all you need is the medication, and the instruction here, use this twice a day and your child's asthma will get better, is absolutely terrible. Because what this doctor is not understanding that just giving a medication or prescribing medication doesn't mean that it's going to actually help the problem. To help the problem, you actually have to get that person to understand why they must take that medication, which will make them more likely to use it regularly, and to show them the best possible technique that they can use their medication in order to get it into the place where it's supposed to be. So this doctor knows nothing about patient-centered care. The principle that patients have the rights to make informed decisions about their own medical care. We have to give them all relevant information for them to make their choices. And in order for them to make their choices, they have to be given the knowledge, the resources, and the skills to allow them to achieve their best possible health. So we don't really, in the modern day era, believe anymore that we must tell people what to do and then people must follow what we say. We do understand now that we have to explain why and show how in order to help people make those decisions and to put them into place. So let's go through some of that background knowledge that we need about getting medication to the lungs effectively. There are different types of devices that you guys have got. Some of you will have an asthma pump. We also call that a metered dose inhaler or an MDI. And when you have an asthma pump, you can either just have the pump on its own, or you can have an MDI, a pump with a spacer. That's the bottle that goes in front of the pump. That goes in your mouth, and then the pump goes at the back. Or you can use that pump with a spacer and a mask. The other drug delivery systems are dry powder inhalers, which we sometimes call DPIs, and nebulizers can also be used in the mouth or used with a mask. And I want to show you what is actually, I think, the only one of the only graphs that we're showing you today. And it might seem a little bit daunting, but what I first want you to do is look at the bottom. It tells you on the left-hand side, we've got a pump on its own. Then next to it, we've got a pump with a spacer. Then we've got a nebulizer, and then we've got a dry powder inhaler. And I think that the first thing that you must notice from this is that the blue areas, the amount of that medication as a percentage that goes into your lungs at the end of using it is actually very, very low, even with the best possible technique that you can do. So first of all, this means that you need to try and do it properly to get even this small amount into your lungs. And secondly, I think that you can see that using an asthma pump on its own, the MDI, the blue area is only about 8%. That almost, in fact, doubles when you use a spacer and pushes it slightly higher than the deposition that you get with a nebulizer and a dry powder inhaler. So a metered dose inhaler with a spacer is actually the best way of getting medication into the lungs. The other important thing that I want you to see is the orange part, which says oral. And there was a question in the chat where somebody says, well, if I use an asthma pump, is there more chance of getting a throat infection? And the answer is yes, because particularly with inhaled steroids, when you spray an asthma pump directly in your mouth, pretty much all of it goes straight into the back of your throat and hits your tonsils and your palate. And that can lead to infections in your throat, which is why it's recommended to wash your mouth out with water after you've used your asthma pump, or alternatively to use a spacer, because you can see that when you use a spacer, that orange area goes down to very, very little. So that avoids pretty much the side effects of getting any thrush or other problems in the mouth. You also have less of that problem with a nebulizer, but you have a great deal of that problem that it goes into the mouth with a dry powder as well. So each of these devices does have their pros and cons, and depending on the patient characteristics and the age of the person and their ability and the severity of the asthma, we need to choose the best device individualized for each patient. But most importantly, and what we're going to cover now, is whatever device that you have, you need to be able to use it properly so that you can get your best bang for your buck. So I'm going to start with the asthma pumps. Asthma pumps, you all know, are nice because you can carry them around. They're quite small, but they also have some disadvantages, particularly when they're used in the mouth, and particularly when they're used in the mouth by young people, because actually kids and many adults cannot use asthma pumps appropriately at all. One of the big problems that people do is that they think that because this asthma medication is coming out so fast, which it is, they must breathe very fast in to try and suck that stuff into their lungs. So they'll end up spraying and then breathing very hard. And when you breathe very, very hard, you don't have a nice, gentle entry of the air into your lungs that can go down to the bottom. You've got a very crazy flow in your lungs, and it all falls out into your big airways that you can see in the middle of your screen. So breathing in slowly but deeply is critically important when you use all of these asthma pumps or nebulizers. But with an asthma pump itself, how quick you breathe in and when you press the pump and time it with your breathing makes a huge difference. And that coordination between pressing the pump and then immediately starting to breathe in, but then breathing in slowly and gently, is very, very difficult for kids and many, many adults. You have to press your pump and start breathing in almost simultaneously. And I'll show you this in a video, but this technique is actually quite tough. So because of the high speed of the spray, most of it lands up in the mouth, and these mistakes reduce the effects. So spacers should be used in children and in any adult with difficult to control asthma. And what we'll be showing you now is the techniques for young children, the techniques for older children and for adults, and the techniques for using a spacer in babies. So let's now actually talk about what does this mean? What is a spacer? We've been talking about it. It's not a spacecraft or a UFO. A spacer is really just a plastic bottle or a metal tube or something that goes between your mouth and your asthma pump. And what that allows us to do is to spray the pump into the air and then breathe the air gently and smoothly and deeply into the lungs. So that avoids the problem of that spray coming out too fast. It avoids the problem of the spray going into the mouth at all and contaminating it. And it avoids that problem of having to time exactly when you're pressing your pump, exactly with when you're breathing. So it increases the amounts to the lungs dramatically. Research shows that we should be using a smaller volume spacer, about 200 or 250 mils for smaller children. This is very small children who have small lungs and breathe in just a little bit. And then a 500 milliliter spacer for older children and in adults. And importantly, like I'll show you in a minute, you do not need a mask to improve the deposition to your lungs, because using a mask doesn't do that. Using a spacer improves the deposition to your lungs. And the only reason we need masks is in little children who cannot put something in their mouth and close their lips around it, because then it's all going to leak out the side. So it's only in babies that you need to use a mask to get around that problem, whereas anybody usually above the age of 3 or so who can put it in their mouth and breathe in and out without breathing through their nose or having a leak out the side, those babies need a mask, but most people don't. So here's going to be a little bit of a couple of videos about using a metered dose inhaler with a spacer and the different techniques and how to individualize it to the age of the patient.
I shake my pump and put it in the back of my spacer. I put my mouth over the valve.
Make sure the valve is between your teeth and your lips are tightly closed so nothing leaks out. Are you ready, Mpilo? Okay, now breathe slowly and deeply all way in and all way out. 6 times, Mpilo. Well done.
So that's a child using a metered dose and a spacer just with a tidal volume breathing. But you can also use, I think we may have skipped a video. Yes, this one. Using the pump with a spacer in the mouth can be done by breathing everything in just one breath or by using 6 to 10 breaths. Younger children have to use multiple breaths and just breathe slowly and deeply in and out of the spacer about 6 to 10 times. With good training, however, most children and adults can learn how to use a spacer with a single breath technique. Watch as we teach this patient how to use their spacer properly. A really good technique to help people use their devices properly is to first demonstrate yourself how to use it, then help the patient do it while speaking them through all the different steps, and then finally allow them to do it while checking their technique. Remember to bring your pumps and your spacer with to every single visit so that you can demonstrate it again and again to fine-tune any problems.
Shake the pump, remove the cap, put it in the spacer. Put the spacer in your mouth with your lips tightly sealed and your tongue out of the way. Breathe out fully into the spacer. This removes all the stale air from your lungs and makes space for new air with medication. When your lungs are completely empty, breathe in slowly but deeply so the medication goes as deep as possible into your lungs. Hold your breath for 10 seconds, then breathe out through your nose.
Check out the patient advice pamphlets on how to use your inhaler device at www.allergyfoundation.co.za. Right, so that technique is to breathe out as fully as possible, then to spray the pump and immediately start breathing in slowly to full inhalation. The video you saw just before that is the little girl who's just using tidal breathing. So she's breathing in and out deeply through the spacer for 6 breaths, all the way in and all the way out, but slowly and deeply, not quick and fast breaths. The third technique that we use for using a pump with a spacer is for the babies that need to use a mask. And as I've said, using a mask can sometimes cause additional problems, so we should stop using a mask as soon as possible. But there are some tips for holding young people, for helping young children to get a good seal. If you look at this picture, I think it's a terrible picture. First of all, this kid is too old to be using a spacer with a mask. And secondly, the adult is holding that pump in front of them, making it very easy for this kid to just escape and turn around and move his face wherever he wants. So what I want you to pay attention now is the technique of using it in an infant, as shown by one of our allergy nurses.
The way a baby uses pump is with a spacer and a mask. The mask is needed because the baby can't close their mouth over the spacer. This makes it easier for the baby, but not for the mom. She has to make sure that the baby is calm, that the mask is fitted tightly over the face so that the air can't slip in and outside, and that it stays on long enough for the baby to take at least 6 breaths.
The mask doesn't actually make the pump more effective. It's just that you have to use it if the baby can't close their mouth over the mouthpiece of the spacer. As soon as the child is able to form a seal around the spacer with their mouth, you can lose the mask, but remember to keep the spacer. The spacer is the really, really important part. So another thing that I want to really bring up and agree with what Peter said about using nebulizers is that we're moving very much against using nebulizers at home or for mild asthma attacks because getting medication into the lungs with a pump and a spacer actually works better. And most importantly, is portable and is something that you're able to do at home. So for a severe episode, or if there's a very bad tight chest, you might not be able to get better if you just use one puff of your reliever therapy. So in this case, we do what is called multi-dosing. And multi-dosing involves giving a lot of puffs of your asthma pump with a spacer to either a child or an adult, but by administering one puff at a time, allowing at least 6 breaths per puff, and shaking your inhaler between each puff of medication. What this has been shown in some incredible data is that it reduces the risk of admission of patients who are treated with an asthma pump and a spacer rather than a nebulizer. They stay in the emergency department for much shorter. So multi-dosing is actually better than nebulizers and is free of many of the other problems of having a nebulizer at home.
When you are having an asthma attack, it's important to be able to get as much medication as possible into your lungs. 2 ways of doing this are either to use a normal asthma pump or a nebulizer. Many people believe using a nebulizer is better than an asthma pump. However, the real difference between the two is the very high dose of medication in a nebulizer. To give enough medication with an asthma pump, we use what we call multi-dosing, using 6 to 10 puffs of the pump over the course of a few minutes. Each puff must be inhaled separately and as effectively as possible, using a spacer and with a long, slow breath. Then you wait about 30 seconds to a minute while you shake the inhaler again and get ready for the next one. Repeat this 6 to 10 times and the effect will be at least as good as a nebulizer.
When you use a nebulizer in hospital, it is powered with oxygen, not with air. The life-saving oxygen is why we use the nebulizer in hospital. A nebulizer used at home doesn't have the same effect and can easily be replaced with multi-dosing.
When you use a nebulizer, breathe slowly but deeply. Short, shallow breaths will not allow the medication to get into your lungs.
So I'm going to move on now away from metered dose inhalers or asthma pumps and quickly cover dry powder inhalers, of which you can see a couple types here. Now, one of the important differences between dry powder inhalers and asthma pumps is that a dry powder inhaler doesn't have any propellant in it, so it doesn't spray the medication out. The only way that you get the medication out of the device is by sucking it in with your own breath. So you need to be able to breathe in strongly in order to use dry powder inhalers. and that is why they are not used in children usually below the age of about 6 or 8 years of age, and they're also not ideal when patients are having a very bad attack because they might not be able to breathe it in effectively enough. But here's some tips about how to do it with the best possible technique.
Using a dry powder inhaler is extremely simple. It requires the person to breathe in hard, so it's only suitable for older children and adults. To use the inhaler, you need to load it. The tape inhaler and the twist inhaler are loaded by twisting. The accuhaler, aerolizer, and ellipter are loaded by clicking the levers.
Breathe out without the inhaler in the mouth so the dry powder inside the device does not get wet. Then, when your lungs are completely empty, put it in your mouth with the lips tightly sealed and your tongue out of the way. Take a strong, deep breath in until your lungs are completely full, and then hold your breath for 10 seconds. Easy.
So I think what's hopefully clear is that patient training and education is critically important to make sure that you can use your medication with the best technique and get the best bang for your buck. But it's very difficult for us as doctors to be able to explain this without having the gadgets right there in front of us. So what's really, really nice is if you bring your medication and your pump and your spacer with to every single visit, then what we can do is we can practice with your own devices and show you how to use them in the most efficient, effective way. One of the other important things that we can do is provide written action plans, which I'll cover in my next talk. So I think that one of the messages that we need to get out about device selection and drug delivery for patients is, yes, make sure your device works for you. Make sure that you've learnt the best possible inhaler technique from a healthcare professional. Take responsibility for your medication. Have your reliever medication with you at all times because you might have an asthma attack. And bring the devices and medication to your visits and follow these specific steps that we've outlined for using pumps, spacers, and nebulizers. Use a spacer with an asthma pump for better medication delivery. Avoid the common mistakes like not breathing out first or not holding your breath after inhaling the medication. And try get regular review and practice of your inhaler technique in order to make sure that you have the best possible asthma management. For the doctors out there, don't be like the guy in this picture. Include the patients in decision making. Allow them to deviate from protocols if necessary. So I've got some kids who are on once a day treatment when they should really be on twice a day treatment because it's part of that patient-centered care. We need to get our patients to understand either relievers and controllers or in anti-inflammatory reliever or smart regimes. We must teach our patients about multi-dosing, normalize them bringing their medication to every visit, demonstrate and assess inhaler technique, and provide lots of additional resources like diaries and handouts and other information that I'll be providing to you in the next few minutes. Excellent. And we're progressing.
Yes,
Moving
we are.
slides? Great.
Yes, we
Okay.
are.
So what I'm going to tell you now about is a last word about where you can get more information and what resources are available for both you or your doctors. So when you go to the Allergy Foundation of South Africa website, which is pretty easy to remember, allergyfoundation.co.za, you will see one of the tabs is patient-related resources. And what I've done is I've cut and pasted those names below you from the website. We've got general allergy, eczema, asthma, allergic diseases, allergens, testing for allergy, allergy treatment, etc., etc., etc. We'll be delving only now into some of the asthma-related resources, but there are more, and there are also resources covering every single other one of those specific areas. There's also a list on our website of doctors who've got special skill and interest in various different types of conditions, including asthma. So if you're looking for a doctor, either in public or the private health service, who can deal with your issues, it's not a good place to find the people who are actually going to be able to help. When we look under the asthma tab, we see all of these different patient brochures that are available. There's myths about asthma, what is asthma, how to control asthma, asthma devices and how to use them. And I'm not going to go through those material or show you that because we've actually gone through most of the things that is on that website already. But please feel free to go and look at these brochures because they will summarize most of what you've already heard today. But there are a couple of things we haven't shown you yet. We showed you an example of an asthma action plan, but here's the actual one that is available on the website. It contains the goals of therapy, it documents regular controller therapy, helps you identify loss of control, and tells you what to do when you lose control. Peter went through this a little bit earlier. The green zone is where you want to be. We want you to be taking your normal controller medications every day, regardless of whether you have symptoms or not, in order to control the inflammation and prevent having any asthma attacks. On the other hand, if you're in the orange zone or the red zone and the action plan tells you how to tell that, you need to actually go ahead and do some additional actions. Your actions in the red zone are to call the ambulance and do multi-dosing to make you feel better. But if you're in the middle zones, you should make sure, if you're in the orange zone, that you go and you get doctor review to make sure that you don't land up having an asthma attack. But sometimes it can be difficult for us to even know ourselves how well we controlled and how many symptoms we're having and whether we've remembered to take our medications or not, because it's chaotic, and remembering things 3 months later when you see your doctor about what happened last month is almost impossible. So I urge you to get hold of one of these asthma diaries. In an asthma diary, your doctor will write down what your controller is, what your reliever is, and exactly how to use them with the best possible technique. But also, there's space for the entire course of the month to write down whether you're having symptoms or not. Are you coughing? Are you wheezing? Having any tight chests? Using your reliever? Or having to go to seek medical care for additional help? Because having a track of the symptoms will allow us to work out whether your asthma is under control or not, and whether there's a need to then do something about that by improving your adherence or your technique or changing to a different medication. So also down there is a really important aspect of this diary, and this is the adherence part of the diary. So there under controller, what we would do is write down whatever controller medication you were on, how many puffs of it you should be using, and then leave it for you to take this home and to tick whether you've actually used that medication in real time or not. And it's really important that when you come to your doctor and they ask you how often you're using your medication, don't fudge things and tell them that you're using it more than you're actually using it. We're not trying to find out so that we can find out that you haven't been using it all the time so that we can yell at you. We're trying to find out, is the reason for your lack of control of the asthma because of something that we can change, like explaining to you and helping you use it more frequently or with a better technique? Or is it because your asthma is genuinely more severe than the medication can cope with? Because that's a very, very different problem that we need to deal with in a different way. So these symptom diaries and adherence diaries really help us very much in making that kind of a decision. We've also got lots of information about our spacer device. Our spacer device, the AfriSpacer, has got some videos and information both on the website but also on its own website at www.afrispacer.co.za. Other resources that we have include the asthma control tests. The asthma control tests are a way of basically working out over the course of the last short while how well your asthma has been under control. And it's got these questions that you do, very, very simple questions to rank in between 1 and 5. Fill that in, pop it into that number, you get a total number, And if your number is greater than 19, then you're okay. But if it's 19 or less, then your asthma is not well controlled. So this is the asthma control test for adults. It's also available for children, and this is the children's asthma control test in Afrikaans. The children's asthma control test has got some graphics that the kids can use to help fill in exactly how good or bad they are feeling, but also some questions for the parents to fill in. But it's got the same scoring system that 19 or less means that the asthma is not well controlled. And we have these materials also in isiZulu and in Sesotho. So in summary, I've shown you some of the materials that we have, but there are many, many more. And in addition to the asthma related things, also, we have lots of things that can help us and help you. So please sign up with us for our info sheets, newsletters, blogs, and competitions. Please select AFSA as one of your 3 possible beneficiaries on your Woolworths My School program. Tell your friends about us and hopefully join us for more of our masterclasses going forward. Thanks very much, and I'm going to hand over to Dr. Duval to do some of the questions.
Thanks, Mike. I think I'm going to direct my first question to Prof. Shaw. Shaw, are you there?
Yes, I am.
I've had an interesting question, or saw a very interesting question from Sumaya Parker. So Sumaya is asking, what is the long-term effect on asthma if you had COVID? I assume that's during the COVID pandemic. Do you have any data or anything specifically on that?
That's a nasty question.
Apologies.
We know that COVID affected our children's lungs in many ways. So whether COVID had a bigger effect on asthma than any of the other viral infections, I think it's still open to debate. We've looked at a few studies, and we've done a few studies looking at the effect of COVID, and it doesn't seem to be more severe than the other viral infections. But we haven't specifically looked at the effect of COVID and asthma outcome. So my educated guess would be to say that more than likely it won't affect the asthma more than the other viral infections. But I mean, Mike, if you want to jump in here anytime now, you're welcome. You're welcome to.
Yeah, I think that you're right. At the very beginning, when COVID started, we were in a massive panic, and we thought that people with asthmatics would be in serious, serious trouble. So we recommended people getting the best possible control and the normal techniques. Fortunately, it wasn't as bad as we thought, and there are other viruses, including influenza virus, but also very minor viruses that normally cause just a cold, that are much bigger problems with asthma than with COVID. I'm not by any means saying COVID wasn't a big deal, because it was, and it killed a lot of people. Fortunately, our new strains, the newer strains, are less nasty and are now almost attenuated, weakened viruses that are floating around, not as bad as they were in the first generation viruses. So we've kind of been able to really discount them as a major, major cause of problems in asthmatics.
Excellent. And then Max van Wyk, I see he's a doctor, is asking about the ALP inhaler. Mike, do you know anything about the ALP inhaler?
The who?
The ALP inhaler.
ALP, A-L-P.
Yeah, E-L-P-N. That's how he spelled it. Yeah, E-L-P-E-N. Inhaler.
I'm not sure what that is, Peter. So
Right.
yeah.
Sorry, Max, we can't answer that. I'm not sure that we've got that in South Africa, and I don't sure where in the world is that.
Yeah, it's not. I've actually just Googled it. It is a type of an inhaler. It's a breath-activated dry powder inhaler, but it's not available in South Africa to the best of my knowledge. Um, yeah.
Okay. And then we've had a lot of comments or questions about nebulizers, Mike. How do you feel about home nebulizers for treating asthma?
So I think that we've very clearly made the point that we should be aiming for excellent control. And if you're aiming for excellent control, then you don't need a nebulizer in your home because the person shouldn't be having asthma attacks. It's better to use your controller treatment, your regular controller treatment with a meter dose inhaler or a meter dose inhaler spacer or a dry powder inhaler because it's just much more convenient. And if your asthma is well controlled, you won't be getting all of these tight chests. And furthermore, even if you do get a tight chest, it's going to be easier and better and more effective to treat it with a pump and a spacer with multi-dosing than with an expensive nebulizer that might have mold growing in it or might have germs in the tubing or we've seen a very famous well-known case of cockroaches getting into things. So you have to be careful about anything that you have at home, that it's easy to clean, that it's maintainable. And I have concerns about nebulizer tubing. In hospitals, we replace our tubing every single time after every single patient. And most importantly, we talked about the reason that we use nebulizers in hospital is because we want to give two different medicines at the same time and oxygen. So we're using it with oxygen to keep you alive and two different things at the same time that are usually not available in a pump. So yes, in a hospital, we will sometimes use nebulizers, but I don't think anybody needs a home nebulizer.
Okay. And then maybe I should just make the comment on food and allergy or food and asthma. Is food a big trigger? Should we test food for asthma? And I think the answer is absolutely no. If you don't have an acute reaction to a specific food, there's absolutely no use. It's actually a waste of money to go on and test for all foods. We know that food doesn't cause asthma, and the link between food and asthma is very poor, if even significant. So I see what people often do is they test a lot of foods and try and see if foods can be linked to poorly controlled asthma symptoms, which is just a waste of money. Unless you have an acute anaphylactic attack where your chest closes up and you start wheezing a few minutes or up until 2 hours after you've taken that specific food, that could be a trigger, but food and asthma has got no link with each other.
Thanks, Peter. I agree completely, and it's one of the big misconceptions. I just want to pick up on a quick point that was a question that was asked, and I made a comment, but I didn't completely finish the comment. Somebody asked about how to protect your health during winter and cold and flu season. Oh, and I see, Peter, you answered correctly. Keep your asthma under control and make sure that you don't have that you have good control so that minor infections don't trigger asthma attacks. But Charles, could you maybe cover the data on which immunizations severe asthmatics should get, either extra or over the, as a seasonal injection? And, how important is it to do extra immunizations if you're asthmatic or got other severe lung conditions?
Yeah, I would like to answer by saying that every single child out there needs to get their general immunizations, your extended program of immunization for South Africa. I think that's important. So 2/3 of all the immunizations in our normal pediatric schedule is aimed towards respiratory infections, and there's a reason for that. And I think it's very important. There are a few extra things we can do. And I would recommend not just asthmatics, but all people out there and all children out there to get their annual influenza vaccine. Influenza is a very dangerous virus, and it's got a very high mortality, a high mortality rate in children especially, and in the elderly. So I think everybody should be getting the flu vaccine. As you've mentioned, the COVID vaccine, it's obviously a much more delicate subject and a much more emotive subject. Most of us probably have had our COVID vaccines. So it's difficult to say. I don't think we've had an updated one recently, but you should have updated COVID vaccines because that can still cause small, well, relatively minor infections that could cause trouble. So why not? If you're not, if you get it, why not? Those are basically the two ones that you can get as extras. There are vaccines on the horizon. There's now registered vaccines against RSV in the elderly population, and in pregnant women to prevent against RSV, but that's more to protect the child against RSV in the early ages. But in the elderly, there is against RSV, which could help there. And in the future, there's a few viruses that are in the virus vaccines are in the pipeline that will keep up to date. I think RSV being the most important one that will probably be available in the next, say, 2 to 5 years in pediatrics. And then they'll probably start working on rhinovirus after that we know is the most important cause of asthma attacks in children. So for the moment, make sure all the general immunizations are up to date, and I would definitely recommend your annual flu vaccine, and then watch this space for future updates on further vaccines that you can get.
Yes. And then maybe really two questions that link into one another. First of all, remission or outgrowing asthma as a child. Is there any specific either data or clear signs or something that you can educate patients on? And then the question that follows that, in your clinical experience, do you see cases of remission on treatment with inhaled corticosteroids, LABA? Or is it only control? How do you clearly define the remission versus control? I don't know either. Prof, Prof Mike, do you want to try that one?
I mean, I'll start with the first part of the question can you outgrow asthma or not? And I think that the first thing is to say that if you've truly got an allergic type of asthma, or even some of the non-allergic types of asthma, it's very unlikely that you're going to grow out of the asthma itself. That tendency to have the inflammation or the other, the problem in the lungs is going to be with you for the rest of your life. But that doesn't mean that you're going to have symptoms for the rest of the life, for two reasons. First of all, you may be treating yourself perfectly with your regular controller therapy, so you're not having any symptoms at all. So you're in remission from a symptomatic perspective, but you're still taking chronic medication, like I do for my cholesterol, and people do for their diabetes and their hypertension and whatever else. And yes, they're in remission, but they need to take some chronic medication. The other thing that can happen, particularly when we get asthma in children, is that they've got that underlying inflammation, but they've also got these tiny little airways because they're little people. And as they grow, they just grow physically bigger, and their airways get bigger, and they open up so that even if they're a little bit swollen, they're not so swollen that they're closed completely and that there's no way of the air getting through. So they stop having symptoms when they often get to, I don't know, like anywhere between 13 and 16, even older sometimes. They look as if they've outgrown their asthma, and some of them stop even taking regular therapy. But then when they're starting to get onto the other side of the hill, which unfortunately with lung growth is relatively early, it's about 30 or so, Charles, that your lung function starts deteriorating again, and that you're not growing, you're starting to shrink. So when you're on the other side of the hill, irritatingly, those symptoms come back again. And in that situation, it's kind of clear that the person has had asthma all along, but for that intervening period, they just haven't had to have therapy. So first of all, I don't think it's necessary for us to worry about whether you can outgrow it or you don't outgrow it, because we can control asthma. And yes, some people will outgrow their asthma, but beware, there might be a sting in the tail and might come back again when they're 40 or 50. With regards to the second question, is there any specific therapy that can help you outgrow your asthma better than any other specific therapy? I think the answer for that at the moment is no. All of the therapies that we have at the moment are aiming to get that inflammation under control, stop you having symptoms, keep you out of hospital, Make sure that you can have your best quality of life, that you can run around, and if you're going to be an Olympic high jumper, that you still are an Olympic high jumper. But in terms of a cure for asthma and one medication helping you to have more of a cure, then there's no evidence that that's the case.
Good. And then this is a second question I'm getting on this. How can I access the best doctor to manage my asthma and allergies? I don't feel like my GP is taking me seriously. So yeah, we've had this before. I think the best is have a discussion or an open two-way discussion with your GP. Discuss or tell him or her that you are kind of unhappy and he doesn't take you seriously. Otherwise, on the AFSA website, like Mike has mentioned, look for someone in your specific area that you can access and make an appointment. I think that's about all the questions, guys. Any other comments or thoughts?
No, just that it's awesome to see a couple of 100 people join us on a Saturday between the rugby games. Thank you so much for joining us, and I'm hoping that you all do join our AFSA family and that you all do sign up us on your Woolworths My School card. Megan, do you have or do you have any final closing things that you need to go through? Oh yes, of course. We've got the small issue of the prizes to hand out.
Yes, we do. One of my favorite parts of our online interventions. I'm just going to start by saying thank you, a very big thank you to our panel for joining us and to the audience for your questions, to the panel for the interactive answering. We do appreciate that. I'm going to announce the winners of our prizes today. Please just give me one moment. Okay, congratulations to Sharon Begunt. You have won the Solenco 204 air purifier unit worth 3,000 Rand. Sitembiso Mpofu, you have won the Beat Allergy pack from Mrs. Martins valued at 500 Rand. And then to our three winners of the AfriSpacer packs, Rosina Hunter, Palesa Olifant, and Patricia Harris-Passard. I will reach out to everybody who has been selected as a lucky winner today to confirm shipping details. Thank you for being an amazing, amazing audience. Please feel free to visit our website to learn more about the products under the AFSA seal of approval. So you'll find that on our website. It's www.allergyfoundation.co.za. Just like to mention that our final allergy education workshop for 2025 takes place on September 27 with a focus on eczema. Feel free to contact admin at allergyfoundation.co.za for more information relating to this or to any of our previous recordings and sessions. If you scan over here, you'll be redirected to the link that has the previous recordings of the past sessions, as well as the MP4s, which are educational MP4s that you can watch at your leisure. This handout is available in the materials section, along with some of the materials that Prof. Mike mentioned in his resources talk. Feel free to download that over there or visit our website, and it's www.allergyfoundation.co.za. Thank you for joining us today. Hope to see you at the next one. Have a lovely weekend further. Take care.